Our didactic speaker is Betty Okere. Betty is a registered clinical dietitian with over 12 years of experience gaining skills in public health, nutrition, health policy development, and advocacy within the civil society engagement, in diverse setups. She holds great mastery in health and wellness education and management, as well as personnel training, with immense experience in non-communicable diseases and young child feeding, health advocacy, and disease prevention strategies. I dare add at this point that Betty is also an established Toastmaster, and the Toastmasters Club is an international club that helps you with public speaking and leadership skills. And she is the incoming president for the current club. Ladies and gentlemen, let's turn our attention to Betty's presentation. This will take about 30 minutes. There'll be a didactic and a case study session within it. And welcome, Betty.
Good evening to everyone, and thank you very much, Ken, for that warm and humbling introduction. My name, as you've been told, is Betty Okere. Very passionate about nutrition, but more so in how we can use nutrition to prevent or delay complications that come as a result of non-communicable diseases. And closest to my heart is diabetes. So today I'm going to talk about medical nutrition therapy in diabetes, management, and its prevention. I'll start with a case, and hopefully at the end of this presentation, we will be able to diagnose correctly this patient and agree with the diagnosis that we've been given or disagree with it. So we are talking about a 69-year-old male who comes to the clinic, a referral from a diabetologist to come and see a nutritionist. Just to inform you that this was the third attempt by the doctor to try and send this patient to be seen by a nutritionist. First, it was a nephrologist. The second time, it was a general physician, of course, trying to find a second opinion. And the third time by a diabetologist. So this is a newly diagnosed diabetic patient, has got hypertension, which is long-standing, meaning they've had it for a very long time. They have chronic kidney disease, and they are overweight. And they also have truncal obesity, as shown by the high waist circumference reading that he presented with on the first day. So if we could quickly have a look at what the labs look like from the time of admission. So I've just simply given the ranges, what are the normal ranges on your far left, and on the first visit, second visit, up to the exit. So one thing you need to realize is that this was a patient who was seen for over 18 months. And so all this may not be like all the data, but just to show you what the changes were. So this person comes in with a BMI of 28.3. And maybe as we go through this, we will we'll be able to define whether that was good or not. Remember, this is a 69-year-old person. Then their waist circumference is at 106. From the presentation, we'll be able to deduct and say if that was good or not, and if we went very low or we were actually within target. Then the glycated hemoglobin A1C, which is the indicator of how well we are doing, how controlled we are if you have diabetes, was at 14.2%, way above what we recommend. Then they had the other lab biochemicals. The creatinine was 129. The glomerular filtrate rates coming in at 49, urea at 22. Total cholesterol was at 3.62, but just to mention that this patient had hypertension as long-standing, but also suffered from dyslipidemia, so was already on a statin. So that might be the reason for having the total cholesterol at that level. And then, of course, the other electrolytes, sodium and potassium. Okay. What is the reason for not having the BP readings and the blood sugar, random blood sugar readings? On the first visit to the clinic, it was 17.8. I think, I don't know what the diabetologist said, but that must have been the reason why he just decided, let me come. And then we were not taking all the other readings because this is one patient who was doing self-blood glucose monitoring at home. And so they had all these readings 6 times, sometimes 7 times in a day. So there was no need to actually really record that at the clinic level. So what are the diabetes-related comorbidities that this patient is coming in with? We are seeing neuropathy. From examination and from the doctor's observation as well, there was a bit of retinopathy, which the patient confirmed that they're really struggling to be able to read most of the times, even when the sugars seem to be controlled. They had never had an eye examination done, so you can imagine. Then there was proteinuria. From the patient and even from the note from the doctor, there was erectile dysfunction. And for the man to actually admit it in front of the wife, then this must have been a problem for a long time. Then there was heart failure as part of the problems. This was a note from the cardiologist who had been following him up for the hypertension. And of course, on foot examination, we noticed that the patient had got a bit of athlete's foot, which is a risk factor for wound development and can even lead to amputations. So much for that case. I know it feels like a case series, or maybe we want to treat a patient right in front of us, but that's the reality. So what am I hoping to achieve by the end of this presentation? One is that at the end of this presentation, we'll be able to discuss what is the role of nutrition assessment in diabetes. And I'm sure one of those questions had that. Then I would also wish that by the end of this session, we'll be able to discuss some of the factors that influence our food choices, as well as discussing the principles of meal planning and describing the common tools that we use in meal planning, and probably having a discussion whether one method is superior to the other, or we can use all of them together, or one is more preferred than the other. But we'll get to know about that at the end of the discussion. So the story or the case that I just presented, when we look at it and we try to think of food, and then this patient is being sent to the nutritionist, maybe the first question that we should ask ourselves, what took him so long? And in our setups, because I know most of us are clinicians, do we always have those instances where you will send your client to go to the nutritionist or the dietitian and they don't feel like there'll be any value added? So as a start, in this country, I know we use the 2 words or the 2 titles concurrently. Either you're called a nutritionist or a dietitian. But in other developed worlds, there is a very big distinction. That a nutritionist is anyone who can give you any information about food. Eat this, don't eat that. I think this is good, this isn't good. I heard that now if you eat an orange, you'll have this. If you don't eat it, you'll have this, and so much more. But a dietitian is actually a protected term to denote somebody who is able to clearly and very well calculate diets, whether the patient is in an inpatient setup or outpatient setup for that particular condition that we're dealing with. And so the work of a dietitian is to be able to provide medical nutrition therapy for whatever health condition that we're talking about. Now, this is actually one of the cornerstones of diabetes management. I don't really think we can manage diabetes without talking about food. And this is information that is best given by a registered dietitian, or in our case, registered nutritionist dietitian. Now, management of diabetes can also not be done single-handedly. Yes, we need everybody in that care team to be present and to play an active role by talking with each other and trying to understand this patient as a whole. The concept of healthy eating should not be looked at as or in isolation. It should be looked at in the context of, does it fit the socio-economic circumstance of this particular client you're talking to? You're not going to tell a client to go and buy asparagus, for example, and they have no idea what that is. Or you tell them in our local language to go and buy mrenda, and they're wondering why they need to eat that slimy vegetable. So what are the socio-economic impact of what you're going to give them when you're trying to discuss healthy eating? Can they afford it? Does their culture allow them to have it? Does their religion agree to what you're telling them to do? They could be Muslim and you're here telling them, yeah, you can have your pork everyone now and again. Or for some reason, they don't believe fish is food and they will not eat it and they haven't been eating it. And what are some of the psychological influences that will be able to come into play when they're talking about their food choices? So yes, it is an important cornerstone of our management, but everything must be in context from who the patient is, and they are a whole. They are not that particular disease that you're trying to control or prevent or manage. So what are our goals when we are trying to look at diabetes nutrition therapy, medical nutrition therapy? One is to be able to achieve targets. So what are the targets for blood glucose levels that you're setting for this patient? Depending on age, the length of time that they've lived with that diabetes, and where are they coming at? At what point are they coming to you? Are they way too out of control? Do they even have the ability to test so that you know if they're getting into control? And then do they have other comorbidities? This particular patient was willing to go all the way down, but look, we also have heart failure in the background. So how tight can your blood glucose target be? What about the blood pressure targets? And what are the lipid targets? So that they're coming in at 3.62. Do you think that's overboard? Do you think that's too much? And maybe we need to do something about it. The other target or the other goal is to ensure that we are preventing as much as we can the rate at which people develop chronic complications. If we're talking about amputations, and the last time I was listening to a presentation on foot and wound care in diabetes management, and they said every 5 minutes, we lose about 3 people to amputation. So just imagine yourself being able to stand on one leg for like 15 minutes. It is usually a task, but an amputee has to do that for the rest of their life. So if you're able to prevent these complications from happening, or we're able to slow down the rate at which somebody falls into complications, like the patient we discussed who has got chronic kidney disease. And as we do this, are we able to address the particular needs of this person? We already talked about the socioeconomic aspects, the cultural aspects of it. And at the end of the day, is the patient even ready and able to adapt to the changes that you're suggesting? Maybe they don't even cook. They're just a husband who's being given food. So what is they're going to say at home, and how does that address their nutritional needs? Over and above, if you're not able from the meal plan or the nutrition therapy that you're suggesting to this patient, provide for pleasure of eating, then the sustainability of your therapy is in question. And again, are we able to minimize the risk factors of developing diabetes if probably they're in pre-diabetes, or they have a risk indicator that portrays that they could easily become diabetic, but are not yet there? Are you able to minimize this risk? For example, are they overweight? What would you do with your medical nutrition therapy to ensure that they do not develop any non-communicable or chronic illnesses? Okay, so much into that. Before we give any medical nutrition therapy advice or counseling or management, we need to have assessed this patient to just try and find out where are they, what is their specific nutrition need. Are they overweight and they need to reduce in their caloric intake so that we do not have excess of that calorie contributing to their weight? Do they have probably not obese, just overweight, but they are suffering from a bit of central obesity? And with the food that you're giving, they also need to take care of their physical activity levels. We also carry out nutrition assessment to try and gauge the nutrition status of this patient. A patient could be coming to you, they look obese and overweight, but maybe they have other nutrition deficiencies, especially of the micronutrients, what we call hidden hunger, and you may not really know about its existence unless you're able to assess this patient. What are the nutritional problems that would prompt you to carry out an immediate action? For example, if it is an old patient, you want to even observe and check if they have the ability to chew. Have they lost their teeth? And there you are suggesting that they go and eat githeri, which in our context in Kenya is a mixture of beans and maize. Do they have difficulties in swallowing? Do they have GI problems? Do they bloat? Do they have GERD as an added complication? And so they're not able to keep their food down for a long time. So those are some of the things that we really need to look at so that you know if whatever you're going to decide at the end of it all works or does not work. What about the drug administration? Does it suit the particular meal plan that you've given? Maybe a patient is on 4 injections of insulin in a day, and you've given them 2 meals. Does that work? What happens on the other times when they're not able to eat, but they have to inject their insulin? Or are they on a medication that may require them to be able to take it in between their meals just so that they can enhance or they can reduce the side effects? A drug like metformin, for example, one of the most common side effects of metformin is the GI disturbance. So are you able to understand that from the assessment so that they don't come back with bloating, nausea, and diarrhea, and you think it's the food that has caused that, yet you have not checked on the medication? And of course, all diet prescriptions must be individualized. And I know most of us in our practice, especially in the public hospitals or resource limited areas where you might not readily have a dietitian in place, we have these tear-offs, which just every patient who comes in with diabetes gets this tear-off or this piece of paper that says in the morning, eat this, lunch, eat this, without necessarily putting into consideration what the needs of this particular patient may be different from the last one. So what are some of the issues that we look at? We want to look at historical data. Do they know if this disease exists? Have they ever had an issue with it? Did they ever see a nutritionist before? Were they told? What is their meal like? And what is the other disease that they know they could be suffering from that would affect the general management? What about their anthropometry, the body mass index, middle arm, upper circumference? You want to check if you have undernutrition, overnutrition, and what you can do about that. Though some of these things, we don't really use them in an urban setup because we probably have other more sophisticated machines like the bioimpedance assessment machines. Or sometimes some people want to dispute the BMI, the body mass index, and they say, we are Africans. Okay. And sometimes people say that maybe I'm an African, so I expect my BMI to be up because Africans are supposed to be, really endowed. Then at that point, you can decide, let me do a waist-hip ratio and decide what is healthy. So if it is for a woman, we're not expecting a waist-hip ratio of more than 0.85. And if it is a man, we're not expecting a waist-hip ratio of more than 1.0, because then that means we have what we call truncal obesity. And of course, what are the biochemicals? The lab works, like we saw in that case that I presented, that would be able to tell you where we are. If somebody walks in with just an EGFR of 49, you already know there's a problem with the kidneys, or they just walk in with a reading that indicates they have high proteins in their urine, even if it's just from a urinalysis. And then what are the clinical assessment? What information do we have about the disease? How does that affect their intake of food and the other comorbidities, and how you can be able to assess that? And of course, the dietary assessment, you want to know what is the variety that the patient is taking, how much are they taking, at what intervals, does it meet their needs, and does it meet their gender, the kind of work that they do? Are you able to see what they took in the last 24 hours? Do they have a food diary with them, which unfortunately most of us do not keep? But there are studies that indicate that people who kept food diaries were better able to manage their weight, especially if they were overweight and underweight, than those who did not. And then, of course, that helps us in trying to do a dietary assessment to collect necessary data, record it, and be able to analyze it so that all that information can form part of the profile that you will use to be able to provide the correct meal plan. So I will not go through these slides in details because basically this is a BMI classification just to show you what is underweight and what is overweight. Sometimes, and why we have this underweight here is sometimes you'll find a patient, because of the nature of their disease, they may not necessarily be overweight, but they could have lost so much weight in the process. For example, a patient who has chronic kidney disease and the management is not going on very well, and probably they've even lost their appetite, may come in with weight loss. Or a patient who just has diabetes, but they are in glucose toxicity, and for a very long time they're out of control, might actually come with excessive weight loss that would make them even underweight. So once we know how to interpret this table, then we know, do we need to give rehabilitation with therapeutic foods, or do we need to supplement while giving counseling and this patient goes at home, or do we just cancel them because they are the normal weight to keep doing what they are doing with a few changes here and there? And if they are obese, what is it that we want to reduce? And how do we also take care of their exercise? For the MWAC, this follows the same criteria. When do we give counseling? When do we give, when do we do follow-ups? And when do we refer for admission? And of course, the same for the children. And to the meat of the day. How do we achieve meal planning to be able to manage and prevent diabetes? The slide that I'm showing at this point is not for everyone, but it is the ideal situation. When we have a patient who has diabetes, what is it that we want to ensure that they are doing so that their carbohydrates are about 50 to 60% at the beginning, depending on what meal planning strategy you will want to employ. And of course, a decrease in their saturated and trans fatty acids, but an increase in their monounsaturated fats, or the good heart-friendly fats. Then, of course, be very careful with the amount of proteins that you're giving, starting at about 0.8 grams per kg body weight. But if there is a problem, like now in this case, CKD, you may want to take that a bit low. And if they're already going for dialysis, you could increase, because anyway, they're going to clean it out. And if they're losing it so much and they're wasting away, you may want to use the nucleotides. And then does this food contain antioxidants and flavonoids, which definitely we get from most of our fruits and vegetables? And are they able they keep reducing a glass every single day and see if the edema will come down, so that we do not compromise on the heart. So what do you think? And I think that was one of the questions. What do you think affects the way we choose, or the type of foods that end up on our tables? One, we may have a national or local influence. For example, for our Nigerian brothers, maybe because they have so much yams, they will be more endowed towards having fufu. And the Kenyans, because of the growing of maize, would be more inclined to having their ugali. And if you go to places like Uganda, then their staple would be matoke. So that doesn't mean that's the only thing they take, but nationally, that is what they are associated with in terms of their food choices. All right. Now, that national influence, if you have no access to food, it will limit what it is that you put on your table. You may want ugali, but in the area where you are, there's no ugali. You snake. So if they have such a kind of information, they may not be able to eat it. And the one that I hear more often is when people say they can't, from a particular community, they say, we can't eat mushrooms because the information they have about mushrooms is that they are poisonous and they are not fit for human consumption. So what is the advertisement that is going on? We have so many of these billboards on our roads promoting fast food, okay? How the food is prepared will also determine whether somebody will eat it or not. So you're not going to have a diabetic patient being told, all your foods must be boiled. Of course, I am not advocating for that. So if all their foods are boiled, it's not palatable. Remember the maintaining of the pleasure of eating, they will not be able to eat it. So how then do we ensure that we actually have a meal plan that will take care of the patient's need? One, it must provide for nutrition adequacies. All the essential nutrients that are needed by this patient must be provided for. Caloric control. Are they overweight? Are they underweight? And what do we want to achieve? How much energy will we provide for the patient so that we do not promote under or overeating? Now, the foods that we are giving, are we able to achieve nutrient density with a very minimal amount of calories for this patient? Because then that will help us to be able to keep the patient healthy. Are we also able to provide variety and balance so that we're not having somebody eating for 14 days in a row githeri, or for 14 days in a row they're just eating meat or they're just eating ugali? Because the more variety and balance you provide, the more the food will be palatable and the more nutrients you'll be able to provide for this patient. Individuality. After the assessment, the nutrition assessment that you've carried out, are you able to tailor the meal that you're giving this patient to fit their particular needs? And are you allowing for flexibility so that if the breakfast had got bread and the next day it was oats, but the oats are not available, they still have the flexibility to choose from what is practically available in their setting? Or are they able to be creative with it and say, well, if I have my arrowroots and I'm only living alone and they're remaining, instead of having my ugali being prepared for lunch, I'd still eat the arrowroots as my starch for the lunch. And is the food pleasing to the eye? Some of us like good food, so if it's not pleasing, we will not even try to eat. And economic feasibility. If it is not within their budget, and when I'm speaking to Kenyans and probably even the rest of the world, I think the rate of inflation is just skyrocketing. So if it's not feasible, it can't fit within their budget, then they'll not be able to take it. So some of the methods that we use for meal planning, this one I am sure is very familiar to most of us, the plate method. And unfortunately, sometimes this is our undoing for our clinicians and our doctors, because we just want a quick fix. We're all giving tear-offs of the plate method. The plate method, we only use it if you do not have somebody that will go into the details of meal planning with the patient, or if the readiness of the patient at that particular point gives all indication that they will be walking a few more steps with you before they accept to make that necessary change. So you can use the plate method. What other method will we be able to use? We can also decide that we will use the handy portion guide. And this originated from Zimbabwe. Representation to create a graphic memory in their mind of how much food they actually need. So if you're trying to demonstrate and you say, for your carbohydrates, I want you to have just a fist size. Now remember, it's not the doctor's or the nutritionist's fist size. It is the patient's fist size. I get that sometimes when I tell the patients, I want you to eat ugali your fist size, and they're thinking, that fist is so small, really. Okay, so then if all their hands are cupped in the palms, you say, I want you to have that much of your vegetables to start with, and then your meat to fit in the palm of your hand with the thickness of your small finger, and of course just a tip of your thumb for your healthy oils. If they cannot afford the healthy oils, as is the case with most families right now, then they can use their other available oils, but in very minimal amounts, probably much less than what is the recommended amount, or other alternatives to sources of oil like the nuts or the avocado and all the other seeds that give us oil. The other aspect that we use is the glycemic index and the glycemic load principle. So in other words, the glycemic index, how fast does food become sugar when it enters your body? Because if you're talking about a diabetic patient, then if they're eating this food that causes spikes in their blood sugar, the overall A1C level at the end of the 3 months will not be very good. And also, they will have very little amount and they get a sugar spike. However, if they are having a much lower glycemic index of the food, then the foods give us sugar, but in a controlled amount, okay? So that we have a smooth curve and not a sharp-tipped curve. This keeps them full for long and they have less sugar spikes, requiring less medication. So when we combine these 3 methods at that point, then we are able to achieve so much more. Something else about glycemic index and glycemic load, the index is how fast that food will become sugar in your body. But the load is what is the quantity of that particular food that we will need to give us the same spike, all right? So a fruit like watermelon, and I know many of us have actually demonized it and said, if you're diabetic, you cannot eat watermelon, don't touch it. The watermelon has got a high glycemic index, but has a very low glycemic load. But the problem is most of us actually end up eating so much watermelon that then the sugars just shoot up. Okay, so that slide again is just to show you in passing what foods would contain high glycemic index and low glycemic index. And of course, we can go further to show what is high, medium, and what is low, and what is very low in terms of glycemic index. But just maybe to summarize this slide is that what usually has got more fiber content will tend to have a much less or a much lower glycemic index. The other form or the other aspect of meal planning that we can put into practice is using the food groups and the food servings to try and quantify what does this patient need in terms of the starches and the breads for their energy. And if these are the servings that they need in a day, what actually constitutes a serving? Because there's the serving size, but then there's the portion, which is the amount that you will have on your plate. So if we take a patient through this, then they're able to know, well, if I need 4 servings or maybe 6 servings in a day, then in the morning I can decide to take 2 slices of bread, which is now 2 servings. I will take my 1 cup of rice, and this has slight differences when you come to low carbohydrate diets. I take my 1 cup of rice at lunchtime because I'm still very active. That's another 2 servings. So I'm already at 4 servings. And then I can take half a cup of pasta in the night, and I will have gotten to my 4 servings that we had decided on. And if I need to increase it, then what happens if I have 3 slices of bread, 1 cup of rice, and 1 cup of pasta or ugali? How would that contribute to my general portion that I take to maintain variety and balance, and of course to provide for caloric achievement? Do I want a high calorie food, or do I want a low calorie or a calorie deficit food to help me with my weight management? And of course, we want to check what in the exchange table, if I was to have this much food, if I was to have maybe 30 grams of fat, what would that translate to in terms of calories, and how can I divide that in terms of grammage for what I will eat at the end of the day? So for me, using both the exchange list and the serving sizes can also be another very important aspect of trying to plan meals for a patient. At this point, I want us to have a bit of an interactive session and ask, which you can respond on the chat, which of these foods do you think is actually healthy? And what are your reasons? Okay, so we can have that discussion going on in the chat. And while we will be doing our discussions, then we can say why we thought.
And then when the meeting ends,
Just type it out in the chat.
We still use Zoom.
Type it out. Type it out. Okay. So just type. Let me know your thoughts. Somebody saying they can't see it. I'll give you a minute to just have a look at it and type out your answers in the chat box. The chat master will be able to help us with that. Okay, and somebody says 1. I do not know 1 from which point. Probably you want to also write what is contained in it so that we know if it is healthy or not. Meal 1, can you indicate what it contains? So as we give those responses, yeah, somebody says whatever has rice with the tuna and more vegetables. Just remember, is it economically feasible? Is it acceptable for the patient? Is it accessible for them? Can they even afford it? So those are some of the things that we need to look at. Then somebody says the one with the salmon, though it looks like it has too much carbohydrates. And of course, somebody says the one with ugali and rice. There's one that I left out, one that has omena. And usually that's people's favorite. They always pick it, but it usually has a lot of carbohydrates. So as that discussion goes on, there is also this new craze that most of us are probably seeing or have experienced, the diabetic foods. And my question, which again you can answer in the chat box, how is it that we have a diabetic food section in our stores, but we don't have a cancer section or a malaria section of foods? What is so special about diabetes that it must have special foods? And by the way, do we even have any foods that are called diabetic foods? Sometimes this is just a marketing gimmick, which is most of the times, and they may not be necessary. Most of them will be very expensive. So the same flour that probably somebody has only added amaranth inside, or they have added turmeric or celery, they will price it as about 300 shillings. Flour. How much more would you buy with that? You just take your normal flour from the posho mill and still be able to buy your vegetables, which celery is a vegetable, and then just buy your turmeric, whether in powder form or in the root form, and use it. You still have gotten what the person who's bought their flour at 300 has received, probably much better. And that does not mean that if it contains celery and turmeric, it will not raise your blood sugar. Okay, so most of these foods are expensive. Most of them, they compromise on the amount of trans fatty acids and therefore also compromising on the level of cholesterol for most of the patients. Sometimes, and which is most of the times, and I will challenge you to go to the supermarket and look at that food which is written low fat or low sugar. Most of the times the carbohydrate content will be high because they know the human mind, when we're talking about sugar, you will go and look at sugar itself. You will not be thinking that when they write sucrose, it is still sugar. When they write fructose, it is still sugar. And then most of the times, these so-called diabetic foods really do not have a role per se in the healthy meal plan. So if I was asked really, I would really run away from that section that says these are diabetic foods. And therefore, I know I have spoken so much, but that is just, I love myself. So I had to just post my picture, doing what I love doing the most. So I allow this point for any discussions, and the host will tell us if you're going into the questions first or we have the discussions first. Thank you very much.
Thank you so much, Betty. It's been a real learning experience, even for me. I mean, I'm thinking about nutritional issues that concern diabetics, but also people without diabetes and so on. So it's an eye-opener for most of us, and I'm sure that many of us here have really gained a lot from the presentation and the case study that you gave. Right now, we will spend about 10 minutes for questions and answers. If you have any questions, please post them on the chat and we will be able to retrieve them and get the subject matter expert, Betty, to give an answer. And of course, if there's any other professionals in the group, they could also give any response that they think that to add on to what Betty has said. Thank you. Any questions? And I can see they're coming in thick and fast. The first one is, we normally advise patients to eat brown. Oh, okay. Well, that's a comment. Let's see the questions coming in, please. Does having white food have an impact?
Do you want me to answer them as they come in?
Yes.
Okay. All right. So somebody says that we always advise patients to eat brown rice and brown flour. I personally don't. Remember what I said, we must maintain the pleasure of eating. If I was born 50 years ago eating my mokimo, and then I get diabetes at age 50, and I have to change my lifestyle, you must convince me beyond reasonable doubt that if I eat the brown ugali, my sugar will not be able to rise. But then what is it that makes our blood sugar rise? Is it the color of the bread or the color of the ugali? Or it is the content of what is contained in that ugali? And I'll go with the latter, because what is the natural process of digestion of a carbohydrate, irrespective of the color? It will contribute to your blood sugar rising. Does that mean that the brown foods are really bad? They are not bad, but they are not the savior. Because where I come from, if you tell somebody to eat brown ugali, do not assume that because it provides a much higher satiety, they're going to eat a small piece, the portion that I was talking about earlier. They're going to still eat a full plate, and that will still have an impact on their blood sugar. So if I'm able to continue providing for my pleasure of eating by eating my white, though I may not get as much nutrients from it as I would get from brown, I would compensate for those nutrients from my fruits and vegetables and all the other sources of foods that I'm eating, but be able to continue eating my white. What is the impact of the white foods on the blood sugar? The more processed they are, the higher the glycemic index, and therefore you require a very small amount, which aesthetically looking at it might play with your psychology and tell you that this is little food. So that is something that we also want to take into account. But then you want to ask the patient, if they were given the choice of brown versus the white, what are they able to take? For brown bread, my reasoning is one. If I gave you 2 slices of white bread, the temptation of adding a third one is always rife. But if I gave you 2 slices of brown bread, because the taste is a bit blunt, you may not want to add a third one. So those are the dynamics. Individualize the plan to fit the patient. If it's an old lady coming to me and they're already eating their brown ugali, then we work on the portion. But I will not definitely change somebody from mokimo to brown ugali just for the sake. No. Then what is the answer to the question that you asked during the presentation? Which was the best meal option? Basically, those meals were just to show you the different people that we have in the society. And one of those meals came from a white client who eats pasta and eats salmon and they can afford it. So there is no way I'm going to have a discussion of matoke with such a client. They have no idea about what I'm talking about. Is the salmon good? Of course it is good. It is healthy fish. But do you know, right now, 100 grams of salmon costs 450 shillings at Carrefour. So how many 100 grams can you be able to afford? So for that reason, I would say, do you have any other fish like Nile perch, which is equally a fatty fish that would be heart friendly? Or will you be able to access your tilapia? Then eat what is available. So the only comment I would make on that is, can they increase their vegetables, reduce the pasta content that you're eating, and then the fish is okay, because then they'll be able to control the blood sugar. Somebody else also had potatoes on the same plate. They had beans on the same plate, you know? So that is just, let's look at the amount of carbohydrates that they're consuming, and depending on the disease, what can we do? And if the protein quantity that they're eating is sufficient for the disease condition. Like the patient we spoke about, we probably need to be very careful about how much proteins we give, because we're already seeing the kidney is really not functioning as well as we would like it to. And so what is...
There's another
that I
question.
already answered. Yes.
There's a question by Emily. My dad is both diabetic and hypertensive. The doctor advised him not to eat fruits such as oranges, mangoes, bananas, etc. Is it wise?
I feel pretty sad for that patient. Now, and I have respect for all the other colleagues in the house, doctors and everybody, but can we just let everybody do their work? And then remember what I said, let's have team participation. You have told the patient that they need to see a dietitian. Allow the dietitian to advise and work with the patient, because there's nothing totally wrong with those fruits. Totally. There's nothing totally wrong. Probably from the self-blood glucose monitoring, when this patient is eating these fruits, we would be able to tell which one causes a sugar spike and eaten at what time, so that we are able to still make them feel like they are not being punished for having a particular disease. So my advice to Emily would be, this is general information for the public, but we would definitely need to speak with that patient on one-to-one to know what it is that they can do and may not want to do frequently. And then a diabetic patient on medication stops the medication and sticks to dietary food, including okra. Is there a danger? Of course there is. There is. I know right now we have a discussion of diabetes reversal. Is it doable? Is it possible? Yes. And I have so many of my patients who have reversed their diabetes, okay? But then, just because you have 1 or 2 readings that tell you your sugar is in the normal range, you are not doing a continuous glucose monitoring system like you're having a sensor which gives you by the second what is your blood sugar level. So I wouldn't really just stop because there's okra. There are a few studies here and there that indicate that okra and I think Karela and I forget the other, I can't remember the other vegetable, have got an insulin sensitizing effect. But the sample sizes are so small, they are scattered, there's no conclusion about them. So I wouldn't really go that way. I wouldn't. Let me see. Yeah, so those are some of the questions that I'm seeing here. Tuna, more vegetables, and white meat. By the way, maybe this is a question that we need to discuss. Why would I tell a patient who's diabetic not to eat red meat? Why? What has red meat got to do with blood sugar rise? And supposing this, so let's have this discussion on the chat. And supposing you're telling this patient to stop your red meat, okay? I only want you to eat white meat. And the only white meat that they eat is chicken. How much chicken can somebody eat? So we really have to be fair with the patient and know what really fits into their schedule. And of course, for everyone in the house, just to discourage you, don't go and tell patients to eat 3 pieces of meat. It is not satisfying. It isn't satisfying. And they will be so hungry and they'll eat so much ugali and their blood sugar will hit the roof.
I think there is a final question. So the difference between brown and I think the question is, sorry, I need to read again. So the difference between brown and white is the level of sugars.
I wouldn't look at it. That's a bit narrowed. That's a narrowed way of looking at it. Remember, there is no one particular food that will heal, prevent, or contain a disease. Okay? We need variety, balance, individualization. Let me give the example of brown ugali versus processed ugali from our stores. So the processed one, when the germ is out, so the fat from the maize is gone, the bit of protein from it is really taken away to make animal feed and all that. The husk has been removed, so the fiber content again has been given to the horses and everything. So if you look at the nutrient value, especially in terms of micronutrients in this processed ugali, it will be so minimal. And because all the fiber is almost gone, the glycemic index will also be high. So that's the impact on the blood sugar, but also an impact on the micronutrient quality of this food. Now we look at the brown, what I would like to call whole. I don't like categorizing it with color, because if I'm looking at my ugali that I've taken to the posho mill, it's just whole and it has everything else. So if I look at the brown, probably there'll be a bit of iron in it. There'll be a bit of magnesium in it. The fiber will be intact. And so a bit that will play on the glycemic index. And so if you eat the same portion as a person who ate the processed, you'll have your sugar rising at different levels, probably provide you with more satiety. So we look at it wholesomely and not just for the color and for the sugar. Remember, we are dealing with a human being who is suffering from diabetes, not just a sugar issue. It's not the sugar numbers. I hope I answered it sufficiently.
Yes. Thank you so much. I think we'll just take one more question. And this one is from Kenneth, who says, red meat is not contraindicated. I think it's a comment. Red meat is not contraindicated in diabetics. If they have other comorbid conditions like dyslipidemias, then we limit fatty meats for more lean meats, but there should be no blanket condemnation. And that pretty much matches what you just said.
Yes. And there's just one that I saw before that. And also just to comment on Kenneth and say that even though we have this dyslipidemia, I think we have had a lot of controversies around cholesterol and foods that give us cholesterol and all that. You know, the issue of the egg, should you eat one egg every week or should you eat an egg every day? And what is the contribution? Actually, when we're looking at dyslipidemia, it is more than the contribution of the food to the levels of cholesterol. It could be familial. It could be you're just having excess calories. And so your body is on a run to produce so much fat. And one of the components is the cholesterols. And so there's no blanket condemnation. Yes, I agree with you. And remember, in our allowance for fat, there's actually up to about 20% allowable of saturated fats that we can eat. So the other question is, how much fatty meat can you eat? All right. And then maybe the last question that I will take is, someone says some doctors tend to tell patients not to reduce intake of ripe bananas because of the high potassium levels. Of course, bananas contain high potassium levels, but why am I controlling your high potassium levels? If I have no reason, then I will not control it. If you have hypertension, for example, and you'll benefit from the high potassium, why not? If you're having high sugars and you're eating very many ripe bananas and your sugars are spiking, then we'll have a discussion about it. But I'll not give a blanket condemnation. Thank you.
Wow, Betty, you've really demystified some of these things that even laymen have been hearing about diet and the nutritional requirements for diabetics. Thank you so much. Thank you very, very much for your brilliant presentation and also for the answers to the questions that have been posted. Let's not leave. Let us now go to the post-session quiz. We will post the quiz again and let's try and answer it based on what we've learned this evening and see just how much learning there's been. We will then ask Betty to give the correct answers to the questions and give a brief explanation. Then we move to the next session. All right, let's get going.
Would we please have more people participating in the quiz? Thank you.
We have 1 more minute. Let's try to get a few more people participating. All right, thank you so much. We can end the quiz, Habil. And then I'd like to invite Betty just to take us through the quiz, the correct answers, and try and explain.
Okay, right. I can see now people have learned. So your sleep patterns may not really affect what you choose for the first question, but if the food is not available, it might actually dictate what you eat. Remember preparation methods. I didn't see somebody pick on that. Yeah, preparation methods will definitely affect what you choose. Remember, food must be pleasing to the eye. All right. And of course, stress levels. Some people are comfort eaters, others do not eat under stress. So that definitely affects whether we will choose to eat or not. And some people will choose high fat, high sugar foods when they're stressed or when they're not stressed. And the opposite is true. Advertising, big time, that affects what we choose. So the only wrong answers, the one that will not influence the food choices is sleep patterns. Then the second one, meal plans can be shared amongst clients with the same disease. That is very false. Sorry, very, very false. Yes, we can't share. Even though you have the same disease condition, you may be a different gender. Your nutrition requirements may be different. So after you do the assessment, then you realize that you cannot have one meal plan that you give to all the patients. And that's what I am trying to discourage here. All right. Then number 3, which of the following statements are true for meal planning? All right. Meal planning is a tedious and expensive process. It's not. It isn't. Once you understand what the patient needs and you've done your assignment, then you will be able to know what is correct. It might be tedious to you if you're not a dietitian, but it isn't. Then prevention, meal planning is for prevention of nutrition deficiencies. Just open the question again. I'm trying to, okay, there, I've seen it. Prevention of nutrition deficiency requires that meal planning addresses variety and balance. Yes, that is true. And then strict or restricted meal planning provides faster and better outcomes. No. You might have very bad outcomes with strict and restricted meal plans. And especially if you're dealing with adults or teenagers, that which you say no to is what they will try to do and see what's the worst that will happen. Then meal planning should provide aesthetically acceptable meals. Yes, that's very true. So the next one is nutrition assessment is the single most important aspect of medical nutrition therapy. No, it isn't. That's a false statement because there's assessment. All right. There is so there's the medical nutrition assessment, there is the clinical assessment, and it's not, there's a drug therapy, so it's, but all the other things must be done together. The nutrition and exercise alone should be used for treatment if indicated. However, it is a false statement. We can't say that we'll only use nutrition to manage all the conditions. Sometimes we need, and most of the times we need to use it in combination with drug therapy and exercise. Yep, and I think that's about it.
Thank you very much. Now, Esther Karaoke, your hand is up. Is there something that you'd like to raise? All right, I think that should be it. And thank you very much, everybody. So I'd just like us to unmute briefly and give a hand to Betty for the wonderful presentation and for agreeing to share her time with us. Let's at least have our videos on and give her a hand. Thank you so much, Betty. Thank you very much. I'm sure we'll be seeing you again soon, because without doubt, there's going to be people wanting to listen to part 2 of this conversation. Thank you very much. And again, we may call you at some other point to talk about nutritional requirements for other conditions. So thank you. At this moment, I'd just like to announce that our next event will be on Thursday, the 28th of July, 2022. This will be at the usual time between 6 and 7:30 in the evening. The topic will be advised in due course, including the presenter. We will advise these using the usual channels, and please come again, invite your colleagues and friends, because these sessions are really, really useful to help us in management of our patients in the settings where we operate. Sam, do you have something to say?
Yes. First, I'd just like to acknowledge the presence of one of the members of the RUFA Executive Committee, Pacifica. I don't know if you are still in the house. Just say Jambo, Pacifica.
Yes, thank you. Good evening, everyone. My name is Pacifica, the way you've heard. I'm a member of RUFA, one of the partners in this program, and I'm very happy to be here. The presentation is just so awful. Thank you so much for taking your time, and wish you everyone nice evening. Let's meet next time. God bless you. Thank you.
Thank you, Pacifica. And we would like to encourage you to let us know if there are any particular topics that you'd like us to address. We are running this series on diabetes. However, we've got many suggestions, and therefore we may be able to put in other sessions or other topics based on what you suggest to us. So thank you very much, and we would appreciate if you could send those to us. Now, we will be, as we normally do, we will send a copy, a PDF copy of this presentation to you, and we will also send the video recording to you so that you can be able to have a point of reference. Thank you very much.
Thank you. Thank you.
Back to you, Ken.
Yep. Thank you, everybody. As usual, we already shared our social media handles. You can follow us, make comments, give suggestions, and anything that you'd like us to cover. And have a very good evening. Since we don't have any further questions or comments, can I wish everybody a good evening and God bless.